The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like More Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Hey, Paul, it's me.
Oh, I hate that.
Trying something new. Welcome back. This is the Curbsiders. I'm Dr. Matthew Watto, here with my good friend, Dr. Paul Williams. On tonight's episode, we're going to be talking about antibiotics. A pretty ambitious script here, Paul. It's a broad overview of antibiotics, the classes, when you might think to use them, some of the pitfalls, the side effects. Our guest, Dr. Adi Shah, he'll tell us about some of his favorite antibiotics and why. And a reminder that this and most of our episodes are available for free CME credit through our partnership with VCU Health Continuing Education at curbsiders.vcuhealth.org. Now, Paul, can you tell the audience what do we do on this show and tell them a little more about our guest?
Sure, Matt. We are the Internal Medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. This was an episode that was put together by the great Dr. Nora Taranto, who is actually not able to join us because she's busy saving lives in real time. So we found out immediately before recording, so she is missed, but did a great job putting the script together. As you mentioned, Dr. Shah, half-jokingly, said basically we were asking him to condense his 3-year fellowship down into an hour-long podcast episode, which is not far from the truth. But he did yeoman's work in trying to do so. So let me tell you a little bit about him. So Dr. Adi Shah, MBBS, is an infectious disease consultant. He has interest in critical care, infectious diseases, antimicrobial stewardship, and infection prevention and control. He works as an ID doctor in Minnesota. He takes himself as seriously as an unneeded procalcitonin level and believes in using social media for education and humor. Probably seen his stewardship memes on Twitter if you're a part of the Med Twitter community. He is a proud immigrant in medicine and believes that diversity is strength, which is a fantastic sentiment. And he did an excellent job in terms of teaching us everything you need to know to get through an ID fellowship in about, 45 minutes.
All right, let's get to it.
No pun, nothing. We're not going to... Folks, you're going to be sick of this one? I don't know. Maybe it's harder than I thought it was.
All right, Adi, we've been talking. I'm already enjoying talking with you, but now we got to let the audience in at some point. So
Sure.
Can you give us a one-liner about yourself and throw in some kind of hobby or interest outside of medicine?
Hi, Matt. Hi, Paul. Thank you for having me. I'm a 33-year-old infectious disease doctor, and I'm living life trying to help people while I try to live with my own insecurities. Every day, man. Every day.
Well,
that's me.
Yeah.
And I like baseball outside of medicine. I'm a big Chicago Cubs fan, and my 2016 record at Wrigley Field was 24-0, including Game 5 of the World Series, and I'm still paying back the ticket. That's me.
All right, well, if you like processing your insecurities, might I recommend doing a weekly podcast? It's a great way to sort of share that publicly. Really amp up your anxiety and just sort of force you to deal with it.
If I just had your talent.
It's a low bar to clear. Let me ask my usual question. Speaking of anxiety and ways to cope with that, give me a book to quell the voices and noise in my head. Is there a book that you've been enjoying recently that you think others would enjoy?
Yes. A book called Unwinding Anxiety.
Oh, perfect.
It says that anxiety or stress is a learned behavior, which includes a trigger, a behavior, and a reward. And we as human beings are just trying to protect ourselves from an evolutionary standpoint. And if you break down every stress and anxiety of yours into a trigger, a behavior, and a reward, then you can somehow understand when your stresses are coming on and work on changing that.
Interesting. So is this that maybe I have to check this out. If you're recommending it, you're finding it helpful. Maybe I have to check this out.
Mm-hmm.
Paul,
you should. It's based on. I just heard recently Ezra Klein's podcast. He's the founder of Vox Media.
Sure.
And he had that guest off the book, and then I went and read the book. And I'm a big fan of Ezra Klein too. And another book I would recommend is his book, which says Why We Are Polarized. I think it's very important for the times that we live in to understand ourselves, our patients, society, and why there is so much conflict of one side versus the other. It enlightened me a lot, and I literally read it in a couple of days. So why we are polarized.
So speaking of good advice, tell us some other good advice you've got, but maybe from a mentor in medicine, whether it was like a peer or a faculty member you've worked with sometime in your career.
Sure. So the best advice I've received was from my mentor, one of my mentors, Dr. Walt Wilson, who is the guideline writer of so many endocarditis guidelines. And he said that learn how to celebrate your successes and continue the feel-good feeling of something good that happens in life, and carry that and feel that feel-good feeling longer than you would despair over a failure. Because we as human beings, we are entwined to just remember our failures longer than our successes. And I think we need to try and reverse that, so that if we celebrate our good things in life and carry that feeling longer than we despair over the bad things in life, that can help us cope with many stresses in life. And I'm trying to do that, man, but it's it's hard. Yeah, it's hard. It's hard. I'm failing at that every day, but I'm trying.
Hopefully not feeling bad about yourself failing at that. Then that would be a self-perpetuating system there.
Absolutely.
Yeah. Paul, it's been a little while. I don't know. Taking a chance here. Any picks of the week? Like, it's just sitting there.
Yeah, I'll give you a pick of the week. I feel like I haven't done music for a while, so I'm going to recommend the album New Skin by the band CRX. It was released in 2016. CRX is a band that is actually, the lead singer was with The Strokes, which is a band I should like but don't. But CRX, the New Skin album is amazing. It's kind of like the Cars filtered through Queens of the Stone Age. It's this very rhythmic power pop, sort of high energy, sort of straightforward rock and roll kind of record that I enjoy very much, and it does not miss. It's sort of all killer, no filler. So if that sounds like it's up your alley, it's the album New Skin by CRX. Okay,
that is that sounds like a great recommendation. Paul, so I actually, this is a pickle week, and if Apple wants to sponsor us, I would just say, so I'm late to the game in this because I've been out of medical school for, Paul, 11 years now, and the Apple Pencil, I bought one in the past 6 months. Reza of CP Solvers, they use that to make their graphics, and he was recommending this to me for the past 2 years. I finally bought one, and taking notes on it is great. You can change the colors easily. You can cut and paste. You can erase, and I've been using it to make figures for our show, and I've been using it to take notes, and you can pull PDFs. There's OneNote works well with it, or just the notepad that comes with your iPad or your phone. And I think it's great. I've been having fun with it, and I would recommend it to the audience. And if Apple wants to sponsor the show, that would be fantastic.
For sure. Our DMs are open.
This episode is brought to you by Grammarly. Audience, we've been using Grammarly for a long time, and here's why. When we're writing show notes, when we're writing emails, Grammarly's there with us. It's checking our spelling. It's making suggestions. We love Grammarly because it makes us sound smarter, and it makes our workflow simpler. The free version of Grammarly is going to give you spelling, grammar, and punctuation, and Grammarly Premium gives you things that I love, like clarity-focused sentence rewrites. That's right. Sometimes I say things in the most complicated way, and Grammarly be like, hey, Watto, maybe say it this way instead, and I love it. Grammarly also is a free tone detector that can maybe get Paul Williams out of a jam, because sometimes he sounds a little angry when he doesn't mean to. So get more time in your day with confidence in your work with Grammarly. Go to grammarly.com/curb to sign up for a free account. And when you're ready to upgrade to Grammarly Premium, get 20% off for being our listener. That's 20% off at grammarly.com/curb. All right. So with that, let's get on to the topic. Paul Williams, would you bring us into it? I don't think we're going to start with a case, are we?
No, I think let's start big. So I think one of the things we wanted to start with is, a favorite parlor game on internal medicine rounds is sort of quizzing each other about what antibiotics cover what. And so you decide to start 2 antibiotics, and do they cover, and do you cover anaerobes for that, and what covers gram-positives, and what's your atypical coverage, and sort of on and on and on until ideally someone's crying. And I wonder... And that seems like a decent way to think about it. But I'm wondering, now that you have a lot of expertise under your belt, what your just general broad framework is when you think about antimicrobials and how to start and what you're starting with. Do you think about it in terms of what they cover? Do you think about it in terms of the types of infections? What's your overarching approach? And then we can kind of narrow it down from there.
Sure, that's a great question. And I remember that on rounds 2 being belabored to the point of exhaustion with those questions. But I, over time, have learned to think about it a bit differently. I first think, why am I using these antibiotics? Is the syndrome more of an infectious disease syndrome or a non-infectious disease syndrome? Who is forcing me or who's asking me that should I be using antibiotics? Do I have time to see how the patient responds to current therapeutic regimens? Obviously, septic patient, ICU, different story. However, if you're going empiric, then what is their past antimicrobial exposure and what is their side effect profile? And what is the suspected site of infection? And do I need to order any specific tests before I start antibiotics to increase my yield of those tests? Remember, blood cultures. And then, is antibiotics enough? Or do I also have to engage source control merchants and the surgeons? So these are the first 5 or 6 questions I ask. Is it infectious or not? Do I have time? Do I have to send any tests before ordering them? What is the site of infection? Do I have source control? And then after this, I think, what am I trying to cover? Because if that's the first question you ask, then you sort of anchor yourself with blinkers and stop the differential diagnosis process right there. And that's my pet peeve when somebody says, let's start vancomycin. I'm like, but wait, let's take a step back. Why? So that's how I approach antibiotics.
I also like that you said you start with the question, infectious or not infectious, because...
First thing, man.
Yeah,
first thing.
Especially if you see the patient that's like persistently febrile and they've been on multiple courses of antibiotics, you have to think, are you missing a malignancy, or is it like a DRESS syndrome, or something like that?
Or my most favorite, somebody comes in with a swollen ankle and
oh boy,
it's been going on for 11 months. And then we get consulted with vancomycin for cellulitis. I mean, you first have to think, if it was really infectious for 11 months, why have they never become septic in the ICU, blah, blah, blah. So that's how I think about it. And that helps me keep the differential very broad. And the more we practice ID, at least where I practice ID and in general in tertiary hospitals, we are making more non-ID diagnoses these days and stopping antibiotics more than we are just starting antibiotics. Because it's easiest to start antibiotics, but it needs some amount of discussion and thinking to stop it.
Yeah. All right.
I feel like the consult a lot of the time is just for permission to do that. Like, it's always such a relief when ID's like, yeah, you can stop antibiotics. You're like, oh, thank God. Like, I wanted to, but I needed someone to give me permission. Thank you for
I
that.
didn't have the guts to do it myself.
Yep.
Because secretly, I think I'm not that smart. So I feel you on that one, Paul. Okay, Adi, so that I love that framework and how you went all the way through from like starting, is this infectious or non-infectious, all the way down to thinking about like the site and pre-testing, source control. So now we're at the point where we're actually going to want to choose an antibiotic. So we have to think a little bit about the spectrum and tell us, like, in big buckets, like, how do you think about the antibiotics? And then we'll dig into, ask some specific questions about each of the classes within those buckets.
Sure. So that's a question like, how do you define the universe? So I'm going to try.
Especially your universe, right?
So I break them down into beta-lactams, which include penicillin, cephalosporins, carbapenems, followed by anti-MRSA agents, followed by tetracyclines, quinolones, and others. Okay.
So that's a pretty good framework.
Very broad.
Very broad. Okay. So the beta-lactams, that's a big group. And in that, you said there's penicillin, cephalosporins, and carbapenems. So first of all, is anyone using penicillin for anything these days? And of course, I know the answer is yes, but can you remind us, like, what role is there for just plain old, good old-fashioned penicillin these days?
Streptococcal cellulitis, it still works. Strep throat, it still works. PenVK for the win. Yep.
Okay. Got it. And probably like syphilis, right? Like that's
syphilis. Oh,
of
course. It still works for syphilis. Right. Yes.
So penicillin, penicillin's not out, but Paul, your favorite drugs? What is it? Amoxiclav?
I mean, yes. not to put too fine a point on it.
Yeah. So we should probably just give that to everyone, Adi. I mean, what?
Well, that's what I'm seeing.
Yeah.
but amoxiclav, yes.
I guess in that class of like what we think of commonly as the penicillins, like if someone says they have a penicillin allergy, we avoid these. I guess maybe a good way to break it down is like, which sites are we generally thinking of these agents for? You mentioned with the plain old penicillin, but for something like, there's amoxiclav and you can mention any other ones you think are relevant and tell us like what sites we might think to use those for.
Sure. So amoxiclav and ampicillin sulbactam work great for oropharyngeal infections because they give you great coverage of oral flora and streptococcal species. That's how I look at amoxiclav and ampicillin sulbactam.
Yeah.
Then amoxiclav can also work for certain skin soft tissue infections. If it's a simple cellulitis, then just amoxicillin can work as well. So that's how I approach them.
Okay. And you were mentioning you have a mnemonic, I believe it was a lame mnemonic for cephalosporins and how you think about those?
Yes. Yeah, so this is going to be a bit longer of an answer. So cephalosporins can be in 5 generations, and the most common first generation cephalosporin is cefadroxil, works good for skin soft tissue infections. Cefuroxime is a good second generation cephalosporin to remember, also for skin soft tissue infections. Third generation can be cefdinir, works good for uncomplicated simple cystitis. And then everybody's favorite IV antibiotic, ceftriaxone, is also a third generation cephalosporin. Cefepime, now you start with the pseudomonal activity, gives you anti-pseudomonal coverage. And then 5th generation cephalosporin includes ceftaroline, which is an anti-MRSA agent. So a good way to remember is as we progress through the classes of cephalosporins from 1 to 4, it gives you more gram-negative coverage. And coming back to the mnemonic lame, cephalosporins do not have listeria, atypicals like Mycoplasma chlamydia, MRSA, and enterococci activity, with the one caveat being that ceftriaxone can be used with ampicillin for enterococcal endocarditis or bacteremias because of the synergy effect.
And isn't there a 6, is it ceftazidime avibactam? Is that...
Ceftalozone tazobactam. These are also great questions. So these are also agents which give you pseudomonal activity. Ceftazidime avibactam and ceftalozone tazobactam.
Usually we'd have you guiding us if we were using that agent.
I hope so, because they should be restricted. And important point, labs run susceptibilities on these, but don't release it. Because if they do, there'll be indiscriminate use and further resistance.
Yeah. We were talking about this in a morning report the other day. Amikacin, like the aminoglycoside, like I always see it on like, for resistant gram-negative. It's like they're always susceptible to it. And I'm like, we never use it. Like,
yes, I hope you don't.
I'm
the first thing listed, so if there's resistance, you're like, oh, that's bad. Like, that can't be. That can't be.
This person's in big trouble.
We would be on the case there.
Okay, so cephalosporins, we talked about. They're good workhorse drugs, especially ceftriaxone. Yeah. And what about the carbapenems? What do you think of those for? Paul and I have a friend. Paul, what's that great Rob Bedecker line about carbapenems? Do you remember? It's like mowing your lawn or something. Like you don't remember? I think he says it's like mowing your lawn with napalm. Like if you were to give it for like, if you were to give it for just any run-of-the-mill infection, it's because it just destroys everything. But do they actually cover anaerobes as well? Gram-positive, gram-negative anaerobes, and what's the gap in coverage with carbapenems?
MRSA. So, and certain carbapenems like ertapenem do not cover Pseudomonas. So the 3 important carbapenems to remember are imipenem, meropenem, and ertapenem. So imipenem could be a situation that I could use it is for something like nocardia. Works great for nocardia disseminated, including brain and lung involvement. Meropenem has excellent anti-pseudomonal activity. And a situation we could use it for is ESBL agents, which I'm sure we'll come to as the podcast progresses. And then ertapenem gives you great gram-negative and anaerobic coverage, but it does not give you anti-pseudomonal coverage. But the benefit of ertapenem is that it's a once-a-day drug, and again, it works good for bacteremias when you're sending patients home. But don't use them if other agents are available because, as you mentioned, these really destroy the good flora that you have in your gut as well, along with the bad guys.
Okay. So that's a good view. And I know we're going to dig into some more pearls probably for all these as we progress through things. That was our beta-lactam group. That was the penicillins, the cephalosporins, the carbapenems. Then you said you have some other classes. So what other ones, in our spectrum, what else do you think of and when do you think of these agents?
Sure. So then I think of anti-MRSA agents. These include vancomycin, daptomycin, ceftaroline, and linezolid. Vancomycin, daptomycin, ceftaroline, or at least vanc and dapto are bactericidal, whereas linezolid is more bacteriostatic. So if you're using linezolid for bacteremia, then it should ideally be used with another anti-MRSA agent because you want bactericidal activity. So that's how I look at MRSA agent: vancomycin, daptomycin, linezolid, and ceftaroline.
And these are more for like your sick, like real sick patients that might be getting intravenous. Because do you think of, I was always thinking of like for community acquired MRSA for like skin and soft tissue, trim sulfa or Bactrim and Doxy. Do you ever use those, or clindamycin for those?
So clindamycin is most ID dogs' least favorite antibiotic.
I'm with you on that.
Because clindamycin, along with quinolones, have high association with risk of C. diff. And the only situation that you can think of using clindamycin is early 48 hours of necrotizing fasciitis for the antitoxin effect. That's when you would use clindamycin. Coming to your point of vancomycin, daptomycin, linezolid, and ceftaroline, yes, most times that you use them are for sick patients right up front when blood cultures are still pending and you don't know what's going to grow from them. And then if there are MRSA in the blood, then you could use these agents. But remember that if the source is the lung, then daptomycin will not work because daptomycin is inactivated by the surfactant. Also, another important activity of vancomycin, daptomycin, and linezolid is enterococcal activity, including E. faecalis, Enterococcal faecalis, and Enterococcal faecium. Again, depending on your local antibiogram. But these are good agents for a penicillin-resistant enterococci too.
Yeah, you mentioned it. Paul, do you look up the antibiogram at your local institution? Like, do you know where to find it? I don't mean to put you on blast. You can lie.
I actually have it memorized. I was going to get a tattoo of it, sort of memento style, but then I didn't realize it changed over time. So.
Right. Yeah, but I do think that it is it's useful, and I know some they do try to make it like if you hang out with the ID on the ID rotation, they always show you where to find it. I wish it was more like front and center, but it is important. Like you mentioned clindamycin, and I was prompting you with for community acquired MRSA, when sometimes people are using clindamycin thinking that someone could have MRSA. I always you have to look up your antibiogram, right? Because a lot of the times there could be like a 30% risk of treatment failure if you look at your antibiogram or more.
And you may have alternative agents like doxycycline can work against community MRSA, and sometimes cefadroxil can work against community MRSA as well. So antibiograms are important, and every unit in the hospital should have its own antibiogram. So like a BMT or a transplant or a cancer unit will have its own antibiogram versus a general medical floor versus immunocompetent patient ICU versus surgical ICU. So it's important to look at unit-based antibiograms as well. And I'll do that frequently, even now, especially for agents like E. faecium and E. faecalis, because they're just very unpredictable when it comes to their susceptibility profile. For example, at our shop, E. faecium, if I see E. faecium, then right off the bat, I would use linezolid because at our shop, it has 100% activity versus only about 50% for vancomycin. But at many other places, vanc would be a fair game first start medication for E. faecium because it works, but not at our shop because of different antibiograms.
You mentioned earlier, and I can't remember if we got this on air or not, sometimes you're still having to look things up. Can you recommend, and without saying, I'm sure you're not getting paid to say this, what apps, like do you have a favorite app or book or something that you look up when you're thinking about antibiotics and certain bacteria? I can say personally, I found the John Hopkins Antibiotic Guide useful. That's been available at some of the places I worked for free. But do you have any that you like to use?
We have our internal antimicrobial guide, and Dr. John Wilson, who's one of my mentors, he's also published a Mayo Clinic antimicrobial guide. I use that often. Then the Sanford guide is good. But again, I don't know how this answer is going to be taken, but I love up-to-date, man. Why not up-to-date? It has got good evidence-based current information, and I frequently look at it. So
usually the articles are written by like titans in their field. I think anybody that's at this point, I think we've all just come to terms with we all love using that product. So it's
but your
fine.
hospitals and most hospitals should have your own antimicrobial dosing guide. So I use that every day. Like when I'm on service, I have a 2-screen. So one screen always has the antibiogram and the dosing guidelines.
Got it.
Why remember things when you can look them up? Yeah. Especially simple stuff like drug regimens.
Right.
So.
Okay.
So
all right. So Paul, bring us back.
No, so I was just thinking, I've heard doxycycline mentioned a couple of times, and I'm just thinking, I've been lately shamed in the show in the past for maybe being over affectionate for clindamycin, and that shaming continues. I'm now hearing that amoxiclav is the antimicrobial choice of the week, which is also a personal favorite of mine. So I'm wondering, you infectious disease hero and custodian of antimicrobials, what favorites do you have? Is doxy among them? Like, what if all the antimicrobials I'm choosing are bad? Just tell me broadly what is good. What do you like? What are your go-tos that you go to all the time that are sort of your hidden gems?
Doxy Norris. So doxy work against acne, works against cellulitis, works against Bartonella from like animal bites, works against ticks, works in COPD exacerbation, atypical pneumonias, community-acquired pneumonias, sexually transmitted infections, penicillin-resistant syphilis. I mean, it's oral twice a day. It's a great antibiotic. However, important to remember that it does have 2 most common side effects, namely photosensitivity and esophagitis. So if your patient is taking it, ask them to take it with a lot of water. I personally, now again, I hope I don't get hated for this answer. Fluoroquinolones have good utility in certain situations. Sure. I know they're associated with C. diff, tendinitis, aneurysms, neuropsych side effects. But again, PO, great oral bioavailability, can be used for even uncomplicated bacteremias. Levofloxacin is once a day. So I like that also in certain situations.
I wanted to plug, you mentioned oral bioavailability of fluoroquinolones, and I know that's one that I always think about. The great Dr. Paul Sachs had one of his HIV ID observations blog posts about like antibiotics with great oral bioavailability. So we can link to that in the show notes, but trimsulfa or Bactrim's on there, fluoroquinolones, metronidazole, and I believe doxycycline's on there. There's a bunch of other ones, but
trimsulfa is a great one too, because again, drug of choice for PJP, drug of choice for nocardia, works great against Tenotrophomonas, works great against toxoplasma, and then your cystitis, UTIs. And as evidence is emerging, works decently in osteomyelitis also because of the reason you just mentioned of having great oral bioavailability.
And while we're singing praises, I love trimethoprim sulfamethoxazole. What adverse side effects should we be aware of as we're actually going through these? It seems to pair up nicely.
Great question. See this all the time. So if you're sending patients on high-dose trimsulfa, it does have some significant side effects, namely hyperkalemia and blood dyscrasias, including anemia, thrombocytopenia, and leukopenia. Also, G6PD issues, right? G6PD-mediated hemolytic anemia. So patients get sent home on these all the time for 7 to 10 days. Make sure you get a complete blood count and a metabolic panel at least once in that treatment course.
Any other maybe it doesn't even have to be side effects, but any pitfalls with some of the common agents or common mistakes that you see people making with antibiotics that you wanted to point out now that you have a soapbox here to like, what other things are people doing that they shouldn't be doing?
So piptazo covers anaerobes. You do not need to add metronidazole when you are on piptazo. That's my biggest pet peeve. Second, daptomycin does not work for long involvement with MRSA, common pitfall. When you're using azithromycin or levofloxacin, always check the QT interval because a lot of these patients have QTCs more than 470. These are some of the common ones that I can think right off the bat. Oh, yes, my favorite, aspiration, pneumonia, and metronidazole. So, history lesson for Paul and Matt. The whole practice of anaerobic coverage for aspiration pneumonia started in the 1970s. Why, you ask? Because the cultures that grew anaerobes in 1970s patients were taken late in the course of their pneumonia, and they were transtracheal specimens, which are higher chance of having anaerobes grow from their cultures. However, we live in 2021 now, and most of the aspiration events are acute events. And in about 36 to 48 hours, the pneumonitis from this acute event usually dissipates on its own. And you do not need metronidazole for aspiration pneumonia coverage. That has made its way out of the ATS guidelines as well, except if you're treating an empyema or a lung abscess. So these are the only two caveats. And I see that all the time. Flagyl or metronidazole is not this, solve-all agent. So that's my pet peeve as well.
And please also don't use clindamycin for aspiration pneumonia.
Yes, because in a couple of weeks, you will have C. diff.
Yeah.
So last one, I want to ask about actually azithromycin because that's another one I see used with wild abandon. So I feel like it's being almost purely safe. Is there anything else we should be concerned about with that?
So C. diff also, along with QT interval prolongation. But it is, again, a good agent, and some of the common etiologies you can use it for are atypical pneumonias, COPD exacerbation, traveler's diarrhea because of emerging resistance in areas that you're traveling to fluoroquinolones. It also has value in non-TB mycobacterial infections. And obviously your skin soft tissue infections like chlamydia, chancroids, mycoplasma genitalium.
All right, so this is all a very helpful start. Why don't we transition to some cases? And we'll start with the cleverly named Mr. Andy Bio, who is a 67-year-old patient. He has a history of COPD and high blood pressure. He tells us that he developed a cough with greenish sputum about a week ago. The cough has not gotten better, and in fact, he's come down with a fever. He's breathing relatively quickly. On chest x-ray, he has a single consolidation in the right lower lobe. Presumably, he got the screening CT scan that was not consistent with COVID pneumonia. He's admitted to the hospital for treatment of his pneumonia. He has no history of recent antibiotics or prior pneumonias. He has no recent inpatient admissions. So before we even get to what antibiotic we'd start considering, or even if we consider one, I just wonder if you could talk us through how you think about just pneumonia in general. What's the framework now? Because it sounds like it's evolved over the past couple of years now. And we think about it a little bit differently now.
Yes, and so there's many aspects to this. You first have to see, is this patient sick enough that needs hospital admission, or can they get an outpatient regimen? So do they need hospital admission, the things that can make or break a case are if they're febrile, their respiratory rate, their age, their basic metabolic markers, are they dehydrated, and so on and so forth. So it looks like this gentleman has fever, they're breathing fast, their respiratory rate is high, and they have a clear consolidation. And just because their respiratory rate is high, they may tire out in a bit, so you want to admit them and get them to an inpatient regimen. The question gives you a lot of information to help you pick the right regimen. It tells you they've never had a recent antimicrobial exposure, or they do not belong, or they do not have healthcare system exposure. And therein lies when choosing what antibiotic you choose as to what patients are at a risk for multi-drug resistant organisms. So if they have heavy healthcare system exposure, if they've been heavily exposed to antibiotics, if they're dialysis patients, if they have been living in a nursing facility or an assisted living facility recently. These are all situations that you would want to cover a little bit more broadly. And then, of course, if the CT or chest imaging is very classic for like an abscess, then you would want to cover MRSA as well with vancomycin.
Yeah.
That's how I think of these.
So like MRSA, you would think like healthcare exposure, antibiotic exposure, and then especially if they have like a cavitating, like necrotizing or abscess, something like that.
Yeah.
And
same for anti-pseudomonal coverage too.
Yeah. And so I always think about, it was when Paul and I were coming up together in residency, it was like community-acquired pneumonia, and then people would talk about HCAP, which is now pretty much gone away. So now it's either gone. They have community-acquired pneumonia with some risk factors for MDRO, which you just told us what would constitute that, or if they've been hospitalized and then they developed pneumonia after they've been hospitalized 48 hours, we just call that HAP, like hospital-acquired.
That is correct.
Okay. But we're talking about here community-acquired pneumonia.
Yes.
And for this guy, he doesn't have those risk factors. What might be a reasonable regimen for like a 67-year-old guy coming in with pneumonia and he's got COPD?
So you would want to pick an inpatient regimen. So you would want to use cephalosporin to cover your simple strep pneumonia species, and then to cover atypicals, you would want to pick either azithromycin, or you could pick levofloxacin, or you could pick doxycycline. So azithromycin and doxycycline are a bit better. Levofloxacin I would hold, especially if you're not discharging the patient immediately. So that would be my first regimen. And then also remember what constitutes atypicals, right? Mycoplasma, chlamydia, these are the two main. H-flu constitute your atypical species. And the good thing about atypical coverage is that it can also give you some Legionella coverage. Now, the classic presentation for Legionella involvement is your waterfalls and hyponatremia and diarrhea and so on. So my first regimen would be ceftriaxone and either azithromycin or doxycycline.
And doxy is much more C. diff friendly, or if the person has like QT issues, it sounds like you might use doxy. So for this guy, if we were to change the case and let's say he had been treated like multiple times for COPD exacerbation, how might you change your initial antibiotics? Like, does he automatically get like MRSA and pseudomonal coverage for this patient?
So it depends on how sick they are. So if they're septic in the ICU on pressors, then you would want to cover for MRSA with vancomycin and then cover some anti-pseudomonal agents like cefepime, or Piptazo can work as well, but do remember that kidney dysfunction with Piptazo plus vancomycin combination, the longer you use, the more chances of nephrotoxicity. If it's just the first 48 hours and then you're going to either stop one of those or stop vancomycin, then vancomycin and Piptazo is okay. However, if the sick patient in the ICU, then you could start with vancomycin and cefepime. Remember to order the MRSA nasal swab. A really good predictive nature of the MRSA nasal swab and MRSA pneumonia. So if you have an MRSA pneumonia, you must have an MRSA nasal swab, which is positive. So how I approach it is, if it's a sick patient, start vanc and cefepime or vanc and Piptazo. Get an MRSA nasal swab. If it's negative tomorrow, drop the vancomycin and continue the other agents. Get some sputum cultures, and if they're in the ICU getting a bronch, then get deeper cultures.
Paul, do you ever double cover for Pseudomonas? Did you ever, I just feel like that is, I've never understood that.
I feel like I knew we were supposed to, or at least I had the sense that we were supposed to, but never actually did. Yes. Was kind of my approach. This is the episode where you try to get me sued for some reason. I'm not sure why you're out. And
I should say, yeah. I'm sorry, Paul. I just want to hear the sound of your voice, sure. Paul. You know that. Come on. And Adi, you did mention to us beforehand, like we should caveat the audience. Like there's many right answers. Like this, we're just talking as colleagues. We're just trying to get a sense of like what might be a reasonable course of option. But there's probably many right answers to some of these.
Yes.
But there's probably clear wrong answers. But
yes,
how do you think about?
Do not cancel me saying, but what about this? Reach out on Twitter DMs. I can take all the abuse.
Yeah, just do it privately. That's good.
But yeah, so that's a great question about double coverage. So if you have a patient who's heavily exposed to the healthcare system, especially patients with some risk factors like recent chemotherapy, bone marrow transplant, solid organ transplant, and they're in the ICU and they're septic on 2 or 3 pressors, then up until you may want to double cover with 2 anti-pseudomonal agents. The options could be pip/tazo along with levofloxacin, or pip/tazo with 1 quart of tobramycin or amikacin, or cefepime and tobramycin or amikacin or levofloxacin. This is so that you can have some double coverage of, if you're suspecting Pseudomonas, till you get the susceptibility results back. However, remember, if it's a floor patient, stable, eating their lunch and waiting, then do not expose them to pip/tazo and levoquin and all these antibiotics, because there are studies that every dose of an anti-pseudomonal agent disrupts your gut microbiome and puts you at a higher risk for C. diff. So that's how I approach it, based on look at the patient. Sick patient, pressors, immunocompromised, heavily antibiotic exposed. Yes, sure, double cover. If not, on the floor, you have time, looking stable, first ever time admitted to the hospital, you really don't need pip/tazo and levofloxacin.
Okay. And I wanted to just give a shout out to that. The ACP I believe it was in 2021, put out this appropriate use of short course antibiotics in common infections, and community acquired pneumonia was part of that. And they talked about how you can consider stopping antibiotics at 5 days for community acquired pneumonia, as long as they've reached clinical stability. So that means like they're off oxygen, they have a normal mental status, their vital signs are stable. And is that your practice, Adi? And like, why are we pushing now for these like very shorter courses? When we talk about UTI and some of these others, we're also talking about shorter courses now. Why is that becoming so popular?
Because we are having more evidence for it. And I just said that every day of an anti-pseudomonal agent increases your chance of C. diff and disruption of gut microbiome. And lastly, shorter is better. And shorter works. As you said, if your patient improves clinically, they're afebrile, breathing normally, feeling fine, back to baseline, then 5 days is fine for community-acquired pneumonia. A frequent question I also get asked is, when can I transition from IV to PO when they're in the hospital? Some of the similar measures that you mentioned, improved respiratory rate, afebrile, feeling better, then you can switch from IV to PO. And just because they're in the hospital, another pet peeve, just because they're in the hospital does not mean IV when hospitalized and PO on discharge. That line is just why? There's no I don't know why.
Think about your patients. They have to be, you're giving them fluid. These people have other medical problems. They're linked to the IV. It's And
great point. So vancomycin, pip/tazo, meropenem, these agents contain a ton of salt. Especially every patient who gets into the hospital gets 3 things: fluids, frequent finger sticks, and lack of sleep. So let's prevent them from getting more fluids and more salt. And especially if it's a patient with some heart failure brewing in the background, you're going to see it, because what's going to happen, they're going to be on oxygen 2 days later, and then somebody will add vancomycin saying, oh, they're not improving, but it's just because of the fluid they're getting from their antibiotics.
All right. Let's
sorry for the rant.
I was going to say, Matt, are you not required by law at this point to reference the great Paul Sachs' essay on choosing antimicrobial duration?
Oh yeah, I'm sorry. Thank you, Paul.
I feel like
we have to,
and Dr. Brad Spellberg too.
So Brad Spellberg has a great website. We talked about it on our ACP episodes recently when he was talking about the IV versus PO for osteomyelitis and some of these other infections. But Paul Sachs had written a blog post, very short, it's like less than a page, I believe, and he talks about how pretty much all antimicrobial regimens need to be a multiple of 5 or 7, and that he talks about all these weird numbers that we never use. If you want to freak someone out, give them like a 6-day course of antibiotics.
Yes, I put out a tweet recently saying, no one, absolutely no one, everyone, 10 to 14 days. 5, 7, 10, 14. Yeah, I agree with Dr. Sachs.
Yeah, so we'll
Totally.
put that in there. It's called How to Figure Out the Length of Antibiotic Therapy, and it's probably my favorite piece of medical writing ever. It's just like, it's very short and sweet. It's hilarious, and I think it still holds true even with
100%.
the newer antibiotic, the shorter durations, because he has all that caveated in there. So it's great stuff.
I'll never forget, this was medical school, and I had an ID attending named Brandon Palermo, who, when we were talking about durations of antimicrobial, he's like, you realize these are all just based on a lunar calendar, right? Like, there's no science behind any of this. I was like, oh, that's a fair point.
I think now we're starting to get some science behind it. But yeah, like there was not much, I guess. Paul, do we?
Yeah, and that's the thing with ID. Sorry to interrupt. There's just a lack of good RCTs because it's hard to do RCTs.
Yeah.
So usually err on the side of caution. That's where all these multiples of 10 and 5 and IV come into play.
All right, let's transition to another favorite infection. Let's do skin and soft tissue and another cleverly named patient. This is Mrs. Diabetes. I cannot believe we've not used that name before. That cannot be possible.
I cannot
There's got to be
believe
a
that.
diabetes in our house. Someone look that up and let me know. But we'll say she comes to urgent care because her foot is hurting her. She says on the plantar aspect of her foot, she has this hot, painful sore that has been draining for some time. She can't really characterize it. It's, say, 2 centimeters by 2 centimeters. You don't see bone, but it's kind of reddish and kind of draining some gook. And she does mention, in case you could figure out by her name, a past history of diabetes is perhaps not well controlled. So, I don't want to make any assumptions here. So, I guess, talk us through your approach to a patient with a diabetic foot wound and how worried we should be and sort of what your initial framework is, then we can get kind of granular on it.
Sure. So I first try to delineate whether it's a deeper infection like an abscess or if it's just a simple streptococcal cellulitis. The difference is that if it's a simple streptococcal cellulitis, usually they sleep at night, wake up in the morning with a red foot, which is painful, hot, warm. If it's an abscess, then it's usually fluctuant or induration going on there or some amount of pus coming out of one of the fluctuant lesions. That's where the differentiation happens. And that's important because if it's simple streptococcal cellulitis without an abscess, then you do not need MRSA coverage. But if it is, then you would need MRSA coverage, and then you perhaps need an IND as well. Now, challenge, and these are really tough infections in patients who are diabetics. Now, if this is the first episode, then first episode of this infection, then that's how I would approach it. But if they're having chronic ulcers, wounds that are open and gaping, 10 days of augmentin here, 10 days of Bactrim there, again and again and again, and if it looks like there's some amount of necrosis coming, then you have to either, based on your physical exam or imaging, rule out osteomyelitis.
And my understanding about the imaging for osteo is that plain films are fine to start with because if you see something, you can use it, you can follow it. If you don't see something and your suspicion is high, you're probably going to need to go for MRI which has better sensitivity. But plain films aren't like completely worthless. I think
they're not.
I think some people might be led to believe that because they've seen enough of them be normal and then you get the MRI and it's osteo. But I think that's just you could potentially save the patient an MRI if it is positive.
Absolutely. And as you said, if you're seeing clear osteo on the x-ray, then don't get an MRI to confirm because we live in times of excesses. And this happens all the time, that even if sometimes the x-ray is positive, you get an MRI. But if the x-ray is non-conclusive, then you may want to get an MRI to have better films to rule out osteomyelitis. And then the gold standard of diagnosis of osteomyelitis is a bone biopsy. So you will always need to engage your ortho colleagues.
What confuses me a little bit is it seems that I've worked in a number of different hospitals at this point in my career, cash lax all throughout the country, and it seems like there's local ways that people when you bring someone in with a diabetic foot, that it's always a little bit of a different flavor with like what the starting antibiotics are, and I just wondered, like, what do you think if let's say you're a new intern listening to this and you're going to be admitting someone overnight and they have a diabetic foot infection, what might be like a good starting regimen for someone who's not like going to intensive care, for someone who's just coming into the floor, maybe they have like a little bit of sepsis, but they're not like crashing. What might be a good regimen?
So if they have fever and elevated inflammatory markers like ESR, CRP, or an elevated white count and clear signs of infection, then obviously you cannot wait for much time before you start antibiotics. If they have a history of heavy antimicrobial exposure, and especially if they're uncontrolled diabetics like our patient, then you need to have MRSA and anti-pseudomonal coverage. Sometimes in diabetics, if there's clear necrosis going on, then remember what bacteria like necrosis, anaerobes. So you have to cover those as well. So a good starting regimen in a chronic wound in an uncontrolled diabetic with some necrosis would be vancomycin plus cefepime plus metronidazole. But the most important part is engaging your surgical colleagues, because if you don't do anything about it, how are you going to treat with what for how long?
Mm-hmm. Sometimes, I mean, if someone goes for an amputation, is something that I've seen a couple times, which I guess in some ways is good for the patient, is that if they get the amputation and they get a completely clean, sometimes I guess they'll get cultures from the residual, what looks like healthy tissue. And if those are negative, they only treat for like 2 to 5 days. Is that pretty standard practice everywhere?
Absolutely. If at that, like if they get an amputation, it's a clear joint or a clear toe that is involved, you get amputation, then theoretically you can just stop then. However, if there's a little bit of overlying cellulitis in the skin surrounding the amputation, as you said, you can give up 48 hours of some antibiotic regimen that they've been given perioperatively and then stop. 5 is too long. I don't know why you would do 5 unless there's extensive cellulitis in the region of the amputation. So, and these are challenging discussions to have with the patients because, it's loss of a part of your body. But if it's a chronic infection and they come again and again, then the best treatment is amputation. You can do weeks of antibiotics. It's not going to work if the tissue there is necrotized and there's no blood going there. How are you going to treat it? Important to note is to also involve vascular colleagues to do vascular studies of your legs to make sure that before you do amputation, make sure that after amputation, the wound's going to heal. And for that, make sure there's good blood supply there.
Yeah. I mean, I think probably part of the reason why I feel so inadequate when treating diabetic foot infections is it really seems like a multidisciplinary. And when you read about it, they're like, you should have wound care, you should have vascular, you should have infectious diseases. If their diabetes uncontrolled, consider endocrinology as well. It's like a big effort to try to pull this person out of it. And it seems like, as we talked about earlier, there's just a lot of room for art when you're choosing your antibiotics and duration. Paul, we talked about this recently after one of our ACP shows about this oral versus IV antibiotics. Let's say we weren't able to cut clean margins and it's not going to just be a short course. It's going to be this person needs 4 to 6 weeks because there's some residual osteo. Paul, have you seen anyone going with just oral antibiotics yet for that?
I have not personally, but that also I do very little inpatient time. So by the time they get back to me, they've probably already completed their antimicrobial regimen. So I might not be the best person to ask.
I just thought maybe some of your primary care patients, if they were coming back to you on an oral for an osteo. Yeah, I haven't seen it yet either, but
I have.
You have. So do you think that's where we're moving now? Like Dr. Spellberg, Brad Spellberg at ACP was talking about, there was a lot of evidence that there's some equivalence between oral and IV for osteo and some of these other infections that we classically thought were just needed IV for 4 to 6 weeks.
Yes, I think that's where the pendulum seems to be shifting, and there's great opportunity for somebody to do an elegant study here. Because why do we pick IV? We pick IV because you want 100% oral bioavailability and get to the site of the infection. But if you have a corresponding oral agent like a fluoroquinolone or trimsulfa that can do something similar, then why not? So I trained in, a community hospital south side of a big metro city, and there are some patients who either cannot afford it or have issues with follow-up or have issues with, maintaining lines and such. So in those situations for osteomyelitis, I have used trimsulfa and I have used fluoroquinolones in the past. But now I work at a different center and I have not used it here, but there is opportunity to do that. Again, it's just based on simple pharmacokinetics and dynamics of the antibiotics.
Yeah, I hope we start to see more of that, because you do see patients, like, in some cases they can't go to their own home even though they want to, because there's no one that can give them like the infusions there, or for whatever some reason for insurance, it's cheaper for them to go like stay in a place and get IV than to have someone come to their house. And it just seems like a very patient-centered thing, that if it is it's true, it seems to be true from the data, that we should be, hopefully we'll start to see more of this.
Yes.
Paul, any other questions about this topic? I mean, I think we've covered a ton. We've given people a lot of antibiotic pearls. We've certainly done other episodes. If people want to go back through the back catalog, we can link to some of our other ID type episodes. But Paul, any last things here?
No, I guess while we have out of here, I would ask any other opportunities for stewardship. I think since that's such an important topic too, is there anything that we didn't discuss that you'd like to talk about in terms of just being mindful in terms of how we choose and what we choose?
Yes. So there's a common misconception about stewardship, is that it's all about stopping antibiotics. That's incorrect. Stewardship means using the right antibiotic in the right dose for the right amount of time for the right patient. That's what stewardship means, not just stopping antibiotics. And second important thing is look at your patient before starting antibiotics and when deciding what antibiotics to pick. And third is guidelines are meant to guide, but you still have to tailor your recommendations based on the patient. So that's what I would recommend. Sorry, that answer was sort of all over the place, but yeah.
I think those are actually like great take-home points for the episode. I think those are great take-home points.
I got one more too, actually. Multi-drug resistant organisms do not care about your feelings or emotions. So if you're just starting an antibiotic because you're scared, MDROs do not care. Also important is sometimes to acknowledge the elephant in the room. Like if you're having a patient with advanced, say for example, dementia or advanced malignant cancer, it's hard to talk about those issues than it is to say, oh, the patient with dementia has an E. coli UTI and 10 to 14 days of something. So remember that these agents cause harm to the patient. So let the clinical evidence and the patient convince you to start antibiotics versus just approaching everything as vancomycin, or vancomycin.
Amen.
Yeah.
All right.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy?
Sure. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox.
And we're committed to providing you with high-value, practice-changing knowledge, but to do that, we need your feedback, so please subscribe, rate, and review the show on Apple Podcasts. You can also contact us at thecurbsiders@gmail.com. I wanted to thank our producer for this episode, the great Dr. Nora Taranto, and to our social media team, Beth Garbitelli on Twitter, Mad Dog Maddie Morgan on Instagram, Tima Karganov is on the website, MJ Allen and Jeff Carter on the transcription team, and Chris the Chew Man Chew is on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
And we would be remiss if we did not thank the great Stuart Brigham for composing our theme music, and we should also thank the amazing Claire Morgan of Notterly for editing our audio. As always, our main Dr. Paul Nelson Williams, thank you, and goodbye.
And Paul, one last thing I forgot to mention, that our friends from VCU Health Continuing Education provide free CME credit for this episode for all healthcare professionals. Go to curbsiders.vcuhealth.org.